And that brings us up to item number
26, House Bill.
item 26, House Bill 979 by Chairman Williams.
Need a motion.
Need a motion? Second. Chairman Williams, you do have an amendment, I do believe.
I do, Chairman. Drafting Code 5346.
Okay, that is correct. All those in favor of the motion in a second? Motion second. All those in favor of Amendment 5346? Aye. All those opposed? No.
Aye.
Ayes have it. Yes, you were properly before us, sir.
Thank you, Chairman. I'm just glad to attach my own amendment. It was fantastic. But first of all, wanted to thank the chairman for his indulgence to be able to do this. We had several people that came and made themselves available to testify if needed on this bill, one of which is very important to me is Dr. Bruce Johnson, who's on the front row there. He's from Cookeville Regional Medical Center and chairman of our board there. We're a private act hospital owned in majority by our citizens of Cookeville, which makes us very unique to most hospitals across the state. But this, for a little bit of background, this bill, for this bill as amended, for over 50 years, Tennessee law has prohibited anesthesiologists, emergency physicians, pathologists, and radiologists from being able to seek direct employment with hospitals. At the same time, hospitals have been allowed to employ other physician types, such as hospitalists, of which I had the opportunity to have my own experience 2 weeks ago with, which was very interesting. This longstanding restriction has created an imbalance and has left our hospitals, particularly mine in rural Tennessee, unable to fully address the staffing issues associated with being able to provide high quality health care to our communities. I've long expressed concern over this, but in the last 2 weeks, it's become apparently clear, particularly when I live in a rural community, how important it is to have people that are employed by your hospital who care about the community, live in the community, and provide those healthcare services to those in your community instead of having someone who's flown in from Denver or Dallas or Pennsylvania in order to provide care just to maintain a contract with an employer who doesn't even reside in your community. This legislation represents a significant step forward in addressing the severe healthcare shortages in Tennessee, particularly in rural areas, and it will make a tangible difference in the quality of care that our citizens hope to receive. As Tennessee population continues to grow and age, the demands on our healthcare system will only increase, not to mention the shortages in just about every category of healthcare service. This bill, for me, particularly is really important because it's a workforce development bill. It allows for us to be able to employ those people in our hospitals that are, as I said before, are invested in our community and know the citizens which they provide health care for. Just as a quick bill summary, based upon this amendment, which makes the bill, this legislation is strongly supported by numerous healthcare organizations, many of which, like my chairman of the board here and many others, include Tennessee Hospital Association, Tennessee Medical Association, the Tennessee Society of Anesthesiologists, Tennessee Radiological Society, Tennessee American College of Emergency Physicians, and the Tennessee Academy of Anesthesiology Assistants. It's a lot of words and a lot of folks, but I'm thankful for their support. This support for these stakeholders highlights the widespread recognition of the need for reform after 50 years of doing it the same way over and over again. This change will provide hospital in those underserved areas with greater flexibility of staffing, helping them to address critical shortages, improve care, and the delivery of that care to our communities. This will allow these facilities to employ specialists in their fields, and by empowering them to make the necessary adjustments to meet those patients' needs. This legislation also allows a hospital employee physicians to work for a specific rural hospital or a children's hospital facility and not the entire system, so that those systems would be under a population cap as it relates to these four practices of medicine, that being 105,000 souls. This means that with a rural hospital in a county under the population, this population limit hires a physician, that employed physician is intended to serve the needs only, let me repeat that, only that community and not another community outside that 105,000. That being said, Chairman and members, I'm happy to attempt to answer any questions that the members might have. I will say one of the discussions is also about anesthesiology assistants. As a part of this bill, been several years of discussion about those assistants. The ratios are dramatically lower for anesthesiologists and anesthesiologist assistants than we currently have under the physician CRNA practice. Very difficult for hospitals to find revenue when doing that. But 22 other states allow for AAs to be employed in their communities. And with the shortage that we have, we feel like this might be a good first step towards providing those services in a correct way. For that, Chairman and members, I'm happy to answer any questions you hope.
Thank you, Chairman. We do have several that want to speak on this bill, so let's go out of session first, if you guys mind. And let's hear from several different individuals. Ms. Janet Setner, Stephen Finder, Kelly Ray, Dr. Louis Chimney, I'm not sure, and Mr. Bruce Johnson. If you'd come forward, y'all can all have a seat on where you might like to be. What we'll do, we had numerous on your list, so we tried to pick out some that we could on each side of the argument. We'll go down the list, name for the record, and then 2 minutes each, if you don't mind. Thank you. Over here to my right. We'll start first with you guys.
This on?
Yes, ma'am. Your name for the record, and then 2 minutes, please.
Jan Setner.
Good to go.
Okay. Chairman Martin and members of the committee, my name is Jan Setner, and I'm a certified registered nurse anesthetist, or CRNA, a retired colonel from the United States Air Force Reserve, and the president of the 65,000-member American Association of Nurse Anesthesiology. Thank you for this opportunity today to speak to you in opposition of HB 979. This bill will not improve access to critical anesthesia services for the citizens of Tennessee and risks decreasing access to anesthesia services. No state or federal law requires CRNAs to be medically directed by an anesthesiologist. This bill forces facilities to employ anesthesiologists to comply with the Medicare billing rules for medical direction of up to 4 CRNAs at a time. Medical direction is the most expensive anesthesia delivery model there is. CRNAs practice autonomously in over half of Tennessee counties, most of which are rural. These facilities depend on CRNA-only anesthesia models because anesthesiologists are concentrated in urban areas. This hospital bill mandates that hospitals use an anesthesia model of care that is not best for their bottom line nor reflect reality. CMS reports that there are 669 anesthesiologists in Tennessee and over 2,000 CRNAs in this state. You have 7 anesthesia programs that graduates approximately 190 CRNAs annually, with 2 more programs being established now. It's important to note that when I deployed to Afghanistan, I was the anesthesia element lead over physician anesthesiologists and CRNAs. There we worked together but independent of each other. I further deployed as the sole anesthesia provider at a forward operating base deep in the mountains of Afghanistan, again, without physician oversight. This is how CRNAs are trained in all nurse anesthesia programs, to graduate with the ability to make critical life-saving decisions independently. Licensing anesthesiology assistants will not improve access to care in Tennessee. Unlike CRNAs, AAs are prohibited under federal law from practicing autonomously and must be supervised and directed by a physically present anesthesiologist under the costliest medical direction model. I respectfully request that you oppose
You're good.
979, and I'm happy to answer any questions you may have.
Thank you, ma'am. And thank you for your service to our country as well. I greatly appreciate that. Next. And we'll do the questions at the end, just so you guys know. We can go through that.
Good morning. I'm Stephen Fender.
You're good to go, sir.
Thank you. Thank you, Chairman, members of the committee. As president of the Tennessee Association of Nurse Anesthetists, I'm here to strongly oppose House Bill 979, which threatens Tennessee's anesthesia workforce, limits hospital flexibility, and compromises patient access to safe, cost-effective anesthesia care. This bill mandates an inflexible, costly anesthesia staffing model in hospitals employing an anesthesiologist in counties under 105,000 residents, and introduces anesthesiologist assistants statewide under vague supervision rules that undermine patient safety. The bill mandates that hospitals employing an anesthesiologist use a 1-to-4 medical direction model, the most expensive and inefficient approach, limiting their ability to tailor staffing to patient needs. No other state mandates this model. Hospitals should decide the best care model, not a statute. This mandate also has the effect of reducing CRNAs to the same limited role as AAs, preventing them from practicing to the full scope of their education and training. Instead of expanding care, the bill forces hospitals that hire an anesthesiologist to use an expensive, rigid model, a lose-lose situation for patients, providers, and hospitals. This bill licenses AAs statewide, threatening CRNA practice, as well as our 7 nurse anesthesia education programs and clinical training opportunities. CRNAs and AAs are not interchangeable. AAs require direct anesthesiologist supervision and can only work under a 1-to-4 model. CRNAs are trained for autonomous anesthesia care and serve in all settings, including rural hospitals where anesthesiologists are scarce. According to CMS data, CRNAs provide 93% of direct anesthesia services in Tennessee. In states where AAs have been introduced, CRNA practice has been restricted, reducing patient access to high-quality care. Make no mistake, this bill will not fix anesthesia shortages. Proponents claim House Bill 979 expands anesthesia access, but that's false. AAs cannot practice independently. Where there is no anesthesiologist, there is no AA.
Great finish there. Thank you, sir. Right on time. And we'll move over. Ms. Kelly, are you next? Okay, yep. Name for the record, and then you have 2 minutes.
Hey, my name is Kelly Ray. Good afternoon, Chairman Martin and members of the committee. Thank you for allowing me to speak to you today. I'm a certified anesthesiologist assistant in strong support of HB 979, president of the Tennessee Academy of Anesthesiologist Assistants, and here today to represent the many CAAs from Tennessee that want to return home to our families to work in this great state, as well as others that would love the opportunity to move here. I received my undergraduate degree in biochemistry pre-med in Tennessee at Lee University before attending Emory University School of Medicine to obtain a Master of Medical Science and Anesthesiology degree. The educational path to becoming a CAA includes completing rigorous pre-medical coursework, earning an undergraduate degree, and acquiring acceptance into an independently accredited CAA program. These master's level programs are 24 to 28 months in length, and students receive comprehensive didactic simulation and clinical training necessary to become safe anesthesia providers. Upon graduation, CAAs have completed over 2,000 clinical hours and administered more than 600 anesthetics. These totals are almost identical to that of our CRNA colleagues in their postgraduate anesthesia-specific training. Students must pass a national certification exam administered by an independent certifying organization. CAAs must complete 50 hours of continuing medical education every 2 years, along with a recertification exam every 10 years. CAAs provide safe anesthesia care in some of the leading hospitals in our country, including Emory and the Cleveland Clinic. A 2018 study by Stanford Medical School compared CAAs and CRNAs working in the anesthesia care team and found no significant difference in mortality, length of stay, or spending between the two providers. Centers for Medicare and Medicaid Services defines a non-physician anesthetist as a CRNA or CAA. I've been practicing as a CAA in Georgia for 8 years. Please support HB 979 because CAAs are highly trained providers and ready to move our family.
Thank you, Ms. Kelly. We'll move on. Next would be Doctor. You have to pronounce your last name so I don't mess it up again.
Oh, no problem. It's Louis Chemin.
Shaman, nowhere close. Thank you, sir.
Oh, that's okay. That's all right. All right. My name is Louis Chemin, and I'm an anesthesiologist and chief of cardiac anesthesia in an independent, non-private equity private practice group. I earned my medical degree from Tulane University and completed my anesthesiology residency and fellowship at Emory University, where I also served as an assistant professor. This bill, House Bill 979, will not alter how anesthesia services are currently provided in hospitals across the state unless a hospital in a rural county or in a freestanding children's hospital in the state wishes to directly employ an anesthesiologist. So suppose a hospital meeting the stated criteria and employs an anesthesiologist and operates under the anesthesia care team model with an anesthesiologist leading a care team comprised of CRNAs or CAAs. In that case, CMS rules regarding medical direction under this bill must apply. These requirements ensure safe and reasonable physician oversight of qualified advanced practice nurses or physician assistants. In non-opt-out states, such as Tennessee, CRNAs must operate under physician oversight. In rural hospitals, this oversight is currently provided by a non-anesthesiologist. The bill permits, but does not require hospitals in counties with fewer than 105,000 residents to employ an anesthesiologist as part of the anesthesia care team model. I have extensive experience in teaching both CRNAs and CAAs. I currently teach CRNAs, taught a lecture just a few days ago at the University of Tennessee, Chattanooga School of Nurse Anesthesia, which gives me a unique perspective on the qualifications and capabilities of these highly skilled professionals. Whether in the classroom or the operating room, I've witnessed firsthand the exceptional expertise that both CRNAs and certified anesthesiologist assistants bring to the table, and I wholeheartedly recommend that certified anesthesiologist assistants be licensed to work in the state of Tennessee.
Thank you, Doctor. And we'll move on to Mr. Johnson. You're now recognized.
Bruce D.W. Johnson here. I'm a cardiac anesthesiologist in Cookeville, Tennessee. Thank you, Mr. Chairman. Thank you, Representative Williams, for all your work on this. This started out with options for corporate practice of medicine alternatives. We had the issue that we all remember 2 years ago, and we need a different way of employing our new physicians and some of our old seasoned physicians. We are talking to people all the time about employment. Most people want employment now. So this is also about scarcity, which this bill helps us address. Scarcity is the overriding economic factors here. That's what drives the prices, and this helps address that. We were very careful when we were crafting this bill, all the meetings between THA, TMA, the different physician groups, to make sure that nothing has to change when this bill's passed. There's no practice that has to change in this state. Not one, nothing. We don't anticipate a change at our hospital. It gives us options, and that's what we're trying to do.
Thank you, Doc. Mr. Johnson, appreciate that. We'll open it up to questions from anything on those portions of it? Chairman Hill.
Thank you, Mr. Chairman. I guess I'll jump in first. That's normally the guy that gets hurt the most. But just a couple of quick questions, just for the record. It was mentioned over here, and please forgive me, but it was mentioned over here that everybody came to the table and has negotiated this grand compromise. Because you brought that up, were the CRNAs included in the conversation?
No, sir.
Okay. And I think it's fair to say that this very much affects their at the very least, they're concerned about it. And another question to the CRNAs. We have a significant compromise bill that's in front of us. Could you speak specifically to your concern about the medical direction, basically the practice model that's being proposed, and what the major concerns are with this? Because, and then I want to open it up if I can, Chairman. I mean, obviously we've got two sides that are deeply concerned about this issue and are trying to work this thing out. But could you speak to that just very briefly? Because I want the committee and I want to hear, your concern, and then why the bill is in this compromise, why it's written the way that it is. Thank you.
You're recognized, sir.
Thank you, Mr. Chairman. I'm happy to answer your question. Our main concerns are that there's no direct supervision requirements. It's very vague how the language is worded in the bill. There's also no written agreements for AAs to practice, and as a delegated practitioner, we're just relying on that the physician will delegate appropriately to the AA, and they would be the only licensed healthcare provider that I'm aware of that lack any kind of written supervisory agreement or protocol to follow. There's also no patient disclosure requirement, so they're not required to identify themselves as an AA that will be delivering the patient's anesthetic. And in Tennessee, we know that we have some pretty strict naming requirements and disclosure requirements for our patients so that they know who's involved in their care and what kind of care that they're getting. Thank you.
Follow up?
Thank you, Chairman. And I guess I want to understand why from your all's perspective, that the practice model is the way that it is in the compromise standpoint. Could you just speak to that just very briefly?
You mean the legislation, how we crafted that? Sure.
Yes.
So we crafted it. There are different methodologies of delivering anesthesia. The medical direction model, 4-to-1 model, that's what most anesthesiologists are used to in a training program. So that's standard flow, and that happens all over the state right now in larger cities, metropolitan areas. In my town, in Cookeville Regional Medical Center, the cardiac anesthesiologists are MDs. We just independently we sit in the chair, call it sitting in the chair, and the rest we have one MD who's there for consultation to help out, to run the board, and the rest is independent practice, or QZ anesthesia is the colloquial term for it. That's the billing term. So again, we're not planning on a change at our place. This just gives us options. But the fear of, I don't see the fear of a medical direction model with anesthesia assistants.
Chairman?
Thank you, Chairman, and thank you for those responses, and thank you all for being here.
Chairman Gant, you're recognized.
Thank you, Chairman. You were just mentioning about the requirements with other states, and it's my understanding that this is a requirement in other states for AA, and PAs in Tennessee are required to have a written agreement here in Tennessee. So why would we not have the same type of requirements for AAs here in Tennessee?
You're recognized.
Thank you, Mr. Chairman. We recommend that we do require them. They should be required for AAs just like they are for other healthcare providers. In 11 out of 16 states that have AAs licensed, they do operate under a written protocol or a written supervisory agreement. We would be one of the very few states that do not operate that way.
Chairman.
And shifting gears a little bit, can you tell me about the training and educational differences between the two?
Sure, I'd be happy to. The difference is, I know that she has a degree in a science degree, but if you look at the differences in the CRNA world, to apply to a program, you have to have a bachelor's of science in nursing, and the average CRNA has anywhere from 4,000 to 10,000 hours of critical care contact with patients prior to applying to the school. We have a national standard to get into the program. We have a national standard in all 141 programs we have across the country for graduation. To compare to the AA, to our AA colleagues, there is not a specific set of rules. Most recently, we were looking at, let's take Purdue for an example, where it states that you can have any degree that you would like to have, and their school is under the School of Pharmacy, and some schools are under the School of Medicine, and some schools, they don't have a set standard on which school that has to be put under. For CRNAs, we do have a 3-year program with the terminal degree of coming out with the doctoral practice, and our training is to be autonomous. We are trained to make critical life-saving decisions independently, and our CAA colleagues are trained to be dependent and must work under the direct supervision and direction of a physician. So there's stark differences in our training and how we graduate.
Okay, thank you, Chairman.
Without objection, let's go back into session. Thank you guys for your questions and all your comments as well. Any questions for the sponsor? Yes, sir, Chairman Williams.
It's supposed to be on. So.
Thank you, Chairman. Just to clarify, obviously there's a rulemaking process as it relates to how this bill goes forward. Is the intent of the sponsor and all those involved that the rules will be promulgated just like they would always be promulgated. The ratios are, in fact, and I won't speak for Copeville Regional Medical Center, even though I represent them, but the using the AA model just doesn't make practical sense because the ratios for AAs and anesthesiologists is so low. But really what this does, it gives them, two things. One, the ability to recruit and retain doctors that come to rural Tennessee to be able to employ them. Secondly, it allows for them to be able to negotiate better terms that they wouldn't be able to negotiate on a different setting, because our reimbursement rates in rural Tennessee are dramatically different than those of a large regional healthcare center in per se in Nashville. And so it makes a huge difference. I believe this is going to improve overall quality of care, and more importantly, it's going to add community back to our healthcare systems in those rural areas across the state. Thank you, Chairman.
Yeah, Chairman, myself personally, I'm a big fan of the corporate practice component. I think that's a great concept. But my concern a little bit, as we've discussed and I've discussed with others, is in regards to the CNA component having a voice at the table. So one thing that I'm looking at or collaboratively thinking is, as we move forward, if this bill does move forward, looking at over the next week potentially some language to clarify or to at least put in writing where some of that area has been concerned. There's some issue with, to the extent of what that might be, and if there's a possibility to work that out, if amendable to you. Thank you, sir.
Yes, Chairman. Obviously, this is a process. There's no way I can know the full impact of all the decisions. I'm happy to look at anything that might have. I did meet with the lobbying firms regarding the CRNAs. There was some discussion. It's not that they've been completely excluded. I think there were just challenges in being able to find something that was tenable for everybody. And those discussions can continue on to full if this committee chooses to move forward with this bill today.
Thank you, Chairman. Chairman Hill, you got a question?
Previous question.
Previous question has been called. That's fine. Without objection, all those, House Bill 979, all those in, Madam Clerk, please open the vote. All those in favor of House Bill 979, vote aye. All those opposed, vote no. Madam Clerk, please take the vote.
Mr. Chairman, 6 ayes, 1 nay, and 2 present not voting.
The ayes have it. House Bill 979 moves on to health full.